This program is brought to you by Emory University.
Hi, good morning. It is truly an honor to present one of our very own, Dr. John Douglas, who is going to talk to us today about hypertrophic cardiomyopathy and key concepts in 2019. Dr. Douglas, if I do my math right, has been at Emory for about 40 years. He has had a very interesting journey, and one thing I thought was very interesting, and I want to hear more about this, is that he was lieutenant in the U.S. Navy Medical Corps and served at Camp Lejeune and South Vietnam. So that was very unique. He was also one of the first to work with a team placing doing coronary angioplasty in the early 80s, and also the first to place coronary stents. So it's just amazing to have you here. And he's a master clinician, and he's also been very interested in hypertrophic cardiomyopathy and septal ablation. So he's going to talk to us and get us up to speed on this topic today. Thank you.
Yeah, I guess you may wonder why I'm interested in hypertrophic cardiomyopathy, but it's a disease or disorder that is extremely heterogeneous. So no matter what your subspecialty is in cardiology, it's likely you're going to have to deal with these patients. Don't have any conflicts of interest. So hypertrophic cardiomyopathy is a monogenetic disorder. It's the most common genetic disorder that affects the heart. It occurs in about 1 per 500 individuals in the country. Maybe a little more, it's been estimated, maybe as many as 1 in 250. It was first tied to chromosome 14 in 1989, and is this beta-myosin heavy chain is one of the more common genes that cause hypertrophic cardiomyopathy. It's a little unusual in a way that about half the affected patients have a mutation that's not been recognized. So it's not particularly helpful to screen patients looking for the gene, but it's very helpful in families. So if you know family member has a certain gene, you can look for it, and if the children don't have it, then they're likely not going to have hypertrophic cardiomyopathy. It can affect intramural coronary arteries, can result in myocyte disarray and scarring, and this is the reason for the increased incidence of sudden death. It can affect any part of the heart. You can have an extremely thick septum, as shown in the upper left. You can have a hypertrophic apex. You can have both septum and posterior wall affected, concentric hypertrophy, or you can have just the septum or just the posterior wall. So it can present in many different ways. The classical asymmetric hypertrophy was first described by Donald Tier in 1958, and this is one of 8 patients he described with, this is pictures from that article, with asymmetric septal hypertrophy. This is the first patient I saw when I was a first-year cardiology fellow in July. My first rotation was at Grady in the cath lab. And this patient came in, and this patient had really no murmur at rest, but with Valsalva or with Amyl had murmur, and you see had SAM-Septal with contact, and had a thick septum. So I've been interested in this problem ever since that time. Doug Weigel described the mechanisms of outflow obstruction very nicely in a Circulation article, 1987. You can see that there's acceleration of flow through this narrow left ventricular outflow tract. The leaflets tend to be a little bit longer and anteriorly displaced, and there's a sail effect that causes outflow obstruction with the anterior leaflet mitral valve contacting the septum. You can see it actually in a cath occasion. This is a patient with hypertrophic cardiomyopathy and obstruction. You see this anterior leaflet mitral valve here, and actually lifts the catheter out of the ventricle. Here you can see a callus is formed on the septum due to the SAM-Septal contact. About a third of the patients have obstruction at rest, as shown on the left. This is a patient who I saw who was sent to me for septal reduction. You can see the bifid arterial tracing, a big gradient, and Brockenborough effect with decrease in pulse pressure after PVC. This patient was markedly symptomatic, as you might expect. The patient on the right has no resting gradient, but a dramatic gradient with Valsalva. This patient also was extremely symptomatic. So about a third of the patients have resting gradient, about a third provocable gradients, and about a third are non-obstructive. This comes from a paper by Barry Marin, pointing out that most of the patients have a fairly stable benign course, but some have sudden death, and sudden death can be the first manifestation of the disorder. About 20% have atrial fibrillation, and then a small group of patients have symptom progression and end stage and have to have transplant. Sudden death in athletes interests me. I had a classmate who had sudden death at age 10, and I've been interested in it ever since that time. There are a number of athletes that have had sudden death: Hank Gathers, Pete Maravich, Reggie Lewis, Flo Hyman are just some of the examples. Really hundreds of folks have died at a young age. These are over 100 that died less than age 40. If you read the Atlanta paper, you'll see examples in the Atlanta paper fairly frequently. This is sudden death in a young basketball player from Lithonia. This is one from Kennesaw, a member of the track team. Said Jonathan had a big heart. He ran big and there were big things in store for him. And he did have hypertrophic cardiomyopathy at autopsy. This is an example of just the newspaper a few days ago. Amani Bell was a varsity athlete at Elite Scholars Academy in Atlanta in 11th grade, and she died during basketball workouts. And hundreds of people came to her memorial service. It's interesting that she had not had a physical exam that she should have had, not that it would have been discovered, but she didn't have the required physical exam. It's not a new problem. This is a poem by A. Houseman, famous British poet, and it's an athlete dying young. The time you won your town the race, we cheered you through the marketplace, men and boys stood cheering by, and home we brought you shoulder high. So the first stanza is about winning the race, and the last stanza is about being buried. Today the road all runners come, shoulder high we bring you home, set you in the threshold down, town smoke still a town. So this poem was read in a famous movie, one of the best movies I've ever seen. It's Out of Africa. And Meryl Streep was a female lead, and she read this poem. I have a little clip of it here. If you'll notice, the book she's reading is Houseman's book. So if you think about in Georgia, there's several athletes almost every year who experience sudden death. And one year there were 3, Ryan Boslett, Shai Owens, and Derek Blankenhorn, with the 3 that died 1 year recently. In Minnesota, there's 1 sports-related sudden death yearly, and nationwide, between 25 and 50 per year die suddenly. When Ryan Boslett died, it created so much controversy and there was so much distress about it that the Georgia General Assembly enacted the Ryan Boslett bill, which said that basically you have to have a comprehensive pre-participation physical exam, which Imani Bell, the girl that died recently, did not have. So Bernie Gersh was the first author on the ACC-AHA guideline statement published in 2011. And class 1 regarding physical activity was, class 2A rather, was that you shouldn't, hypertrophy should not engage in competitive sports. There's a lot of controversy about that. You'll read recent articles suggesting it maybe it's safer than we thought before, and that maybe there's some relatively active sports that these guys could participate in, but the guidelines haven't really changed. Sudden death associations are severe hypertrophy, particularly greater than 3 centimeters in thickness, family history of sudden death, and then history of cardiac arrest are the principal associations. So prevention of sudden death is a critical management goal. Then relief of symptoms with medications, with alcohol ablation, and with surgery. And Gersh's article gave class 1 beta blockers should be used to titrate a heart rate of about 60 to 65. Verapamil is useful to, as an alternative or in addition to beta blockers. Disopyramide is less frequently used. Guidelines for septal reduction in that article gave considerable weight to myectomy over alcohol ablation, and stated that class 2A would be, first choice would be surgical myectomy, and then alcohol ablation could be performed in patients with high surgical risk. And class 2B would be alcohol ablation as an alternative to myectomy. At the time these guidelines were written, there was not very much long-term follow-up of patients who had had alcohol ablation. When the European guidelines were written in 2014, they upgraded myectomy to class 1, and also upgraded alcohol ablation to class 1, and gave them equal status. So in Europe, actually very few myectomies done, and alcohol ablation is by and large the first choice in patients that need septal reduction. Myectomies are quite effective. There's some data from Cleveland Clinic showing that there's a reduction of septal thickness, and the gradient goes down dramatically and stays down. And the prognosis of these operated patients is really quite good. Barry Marin is one of the authors of an article in Circulation this past year, making the case that myectomy should be really performed earlier, before the patients get markedly dilated atria and atrial fibrillation. And it'll be interesting to see how this plays out. Alcohol ablation was first done in 1994 by Sigvard, did 3 patients, and they had good relief of outflow gradient and good long-term prognosis. And since that time, there have been many thousands of patients done, particularly in Germany and in the United States. The way this is done is to find the septal branch that supplies the part of the septum that contacts the anterolateral mitral valve. And you can test it by injecting contrast and use either transthoracic or transesophageal echo, and then inject the alcohol and infarcts this area. And patients do remarkably well. It's an example of a patient I did about 15 years ago. We did the alcohol ablation on a Wednesday. Patient had atrial fibrillation, was being bridged to Coumadin anticoagulation, and over the weekend had a retroperitoneal bleed that wasn't recognized, and the patient died. And this is the autopsy result. You can see this necrosis of the septum, primarily on the left side. It's just the what you like to achieve with alcohol ablation. It's an example of a patient that we did alcohol ablation on several years ago, age 59, was markedly symptomatic, had the typical murmur, had a outflow gradient of 70, fairly thick septum at 2.6, and had moderate pseudomitral regurgitation. So this is his echocardiogram. You can see the SAM-Septal contact, markedly thick septum, and mitral regurgitation. So he had a substantial gradient at rest. This is coronary arteriogram, had a fairly large septal branch you can see here. So we tested that one, and it produced brightening of the basal septum, and then gave alcohol. You can see the brightening here of the basal septum. It's absolutely remarkable to me, but the SAM goes away immediately. Once you give the alcohol, it goes away. The mitral regurgitation becomes less, frequently goes away completely. And so the patients feel better immediately. We did a patient last week, and the same day she was up walking around, felt great, hadn't felt that good in decades. Typically, you get occlusion of the branch, septal branch, but not always. This patient did get occlusion. This is the pullback pressure tracing. Patient had no gradient at rest. Even with nitroglycerin, there was no gradient. This patient developed a left bundle, which is somewhat unusual, but that happens occasionally, and had a dramatic symptomatic result. Actually stopped medication and stopped seeing physicians, and basically was totally asymptomatic. This is his echo at 6 months. You can see what's very similar to the result you would get with a myectomy. No SAM at all, no outflow obstruction. So the difficult task we have, though, in doing alcohol ablation is finding the septal branch that supplies the left side of the septum, and it's always been a little bit difficult, but sometimes it's literally impossible. I'll show you some examples of the difficulty that one can experience. And the second problem we have is knowing when to stop, because you get some stunning with the alcohol. So although you may get rid of the gradient completely, you may not have done enough work. And we try to avoid unnecessary alcohol because of the risk of complete heart block and need for pacing. It's a study that was done at the Mayo Clinic. They took 20 patients who had myectomy and 20 who had alcohol ablation and did MRIs. And what they observed is that with the myectomy, you get a very reproducible divot in the anterior part of the septum, on the left side, obviously. And when they weighed the muscle, it was about 6 grams. And what they observed with alcohol ablation is about 75% of patients get a transmural septal infarct that's a little bit more inferior than ideal. You see, this is more inferior than the myectomy. And about 25% get infarction of the right side of the septum, which does not relieve the pressure gradient. So we do have to go out of the way to try to find the septal artery that supplies this part of the septum. It's an example of a patient from that article that had infarction of the right side of the septum. See here and here. So this patient would get no relief of outflow gradient. So what we do is we use myocardial contrast, try to find the septal that's supplying the SAM-Septal contact point, and then monitor the outflow gradient. As an example, upper left, patient who has a thick septum, SAM-Septal contact, pressure gradient was about 70, had mitral regurgitation. So we went to this septal branch, put the balloon there, injected alcohol. You can see that you get brightening of the septum. Then gradient was reduced to 19 millimeters with nitro and Valsalva. Mitral regurgitation went away and the septal branch was occluded. It's an example of a patient with a tiny septal branch, and it works just fine. We were able to wire that, put a balloon there, inject contrast. You see this brightening of the basal septum. Pressure gradient was reduced from 80 to 8 millimeters. Patient got a very nice result. It's a patient with a gigantic septal branch that we decided just to treat a portion of it. Pressure gradient was 100 at rest. So here's our balloon catheter in this posterior septal branch. Got brightening of the septum, and the pressure gradient was reduced to 11 millimeters. This patient with a nice septal branch from the LAD. So we went down that first, and what we observed with contrast injection was brightening of the right side of the septum, as shown here. You see this is the left side. So brightening of the right side is not good. So we went back and went into the septal branch off the diagonal. And we're here. And we got brightening then of the left side of the septum and complete relief of the pressure gradient after injecting alcohol. As it turns out, not all septal branches from diagonals are useful. This septal branch here we thought would be ideal, so we wired it, put a balloon in. We did get brightening of the septum, but we also got brightening of the papillary muscle. So if we had injected that branch, we'd have probably catastrophic mitral regurgitation. So we went down and found another branch off the LAD, put a balloon here, got brightening of the septum, complete relief of the gradient, and this patient got a good result. It's a 63-year-old female with gradient of about 100, had a thick septum. We tried to wire this branch here, the tiny branch. We couldn't wire it. We could wire this branch, and we tested it with contrast, and we thought it looked pretty good. In retrospect, we noticed that this part of the septum wasn't brightened, and that's really the SAM-Septal contact area. After injecting alcohol, the septal branch was occluded. Pressure gradient was reduced to 16. So we thought we'd done a pretty good job. As it turned out, this patient subsequently had return of outflow obstruction, return of symptoms, and showed up here 2 years later with an outflow gradient of greater than 100. And you can see both outflow obstruction here, turbulence, and mitral regurgitation. So if you look carefully, what you can see is that the septum was about 1 centimeter here, but in the most basal part was almost 2. So we had actually missed the SAM-Septal contact area, and you can tell right here that that area is relatively thick. It's an example of a patient from the Mayo experience where with myectomy, you get a nice complete relief of the thick basal septum. And this particular patient who was a hypertroph, had alcohol ablation, the reduction in septal thickness was too distal, and this is exactly the experience we had with our patient. So this is a second ablation. You can see on the upper left a big gradient, bifid arterial pressure tracing, Brockenberg effect. So we came back and tried to wire that branch again, this one right here, and we couldn't get a wire down. So we went to a branch off the diagonal, got pretty good brightening of the septum, injected alcohol, relieved the resting gradient, but notice there was a Valsalva gradient, but we thought we probably had done all we could do, so we stopped. And what we noticed that patient's murmur came right back. So 48 hours later, the patient had big gradient. You can see the turbulence and mitral regurgitation. So we came back. We felt like we had to wire this branch right here. We used a venture catheter, which you can deflect the tip of. So this is the venture catheter with deflected tip. We were able to enter that small septal, got nice septal brightening, complete relief of gradient. So that's 3 ablations. The only patient out of 350 that we had to do a third ablation. This patient got a great result, totally asymptomatic, walking without any problem, and feels great. On the right, you can see thin septum and absolutely no SAM. So who are candidates? Obviously patients who fail medical therapy. We've done a few who are class 2. Most of them are class 3 or 4. Generally, we'd like the septum to be at least 1.5 centimeters and preferably thicker. And it's helpful to have SAM and to not have a mid-ventricular type obstruction. We summarized, looked at our data when we had 210 patients. As I mentioned, we now have 350. Mean age at that time was 59. The gradient was about 60 at rest, over 100 provoked gradient. And if we define procedural success as greater than 50% reduction in gradient, and we were successful at 98%. Final gradient was less than 20 in majority of patients, and the peak CK release was about 1,000. We had 1 cardiac death, a death in the lab. We had 2 non-cardiac deaths. One was a patient who developed sepsis due to tracheal intubation and died of sepsis, and other death was a patient with retroperitoneal bleed. Very few complications otherwise. Did need permanent pacing in almost 20% of patients. And this is data from the Cleveland Clinic, Mayo Clinic rather, where they have needed pacing in 17%. So our results, although a little higher than than average, are not much different from our Mayo Clinic experience. There's a group of patients, these patients who are hypertrophs, who've been markedly disabled, and then suddenly can do almost anything they want, are extremely grateful. So I get cards and letters. This is one I got in 2013. Today it's been 9 years since my procedure. I still feel great. You're still my hero. And then at 15 years post-procedure, this is my annual email. I get email every year on the date from the patient. Still feel fabulous, and she's now retired. Mayo Clinic looked at a group of patients who were age and gender matched, followed long term, and the survival was good and the same. Bobby Leonardi, you might remember, is one of our former fellows, was from Charleston, and did a meta-analysis. About 2,000 patients that had myectomy and 2,000 had ablation. Myectomy patients were about 10 years younger. The septum was a little bit thicker than the myectomy patients. Otherwise, very similar characteristics. All-cause mortality was the same, and sudden cardiac death rate was the same. Another more recent meta-analysis in which they took patients who had been from the same centers, 10 different centers, and you can see here 30-day mortality, no difference. Long-term cardiac mortality, no difference. Sudden cardiac death, no difference. And there's been recent publication from a German group. They'd done alcohol ablation on about 1,000 patients. And this is a plot of estimated survival free of cardiac events out to 15 years, and it was 96.5%, so extremely good long-term outlook in these patients who have had alcohol ablation, and I think it's very reassuring, and I think it's going to mean that we'll see more and more patients for alcohol ablation. So to summarize, this hypertrophic cardiomyopathy is a genetic disease characterized by abnormal hypertrophy. Class 1 indication for managing these patients are lifestyle changes, pharmacological therapy, primarily with beta blockers, and sudden cardiac death prevention strategies. Medically refractory patients who have outflow obstruction can have either myectomy or alcohol ablation with similar symptom relief and good long-term outcome. So thank you, and I'd be happy to answer any questions.
So,
what do you advise your patients regarding activity after the procedure? I mean, not just short term, but long term. I mean, do you still
I suggest they don't be marathon runners or that sort of activity, but otherwise they do pretty much what they wish.
John, that was incredible, and it's interesting that you're so well known for PCI across the world. But you know, this is a huge advance, and I think you've served a lot of patients in the program so well. You know, I was interested. You've always taught us that looking for these septals are key, and using echo is critical. And some of the examples you showed, it's sort of remarkable that you really have to kind of fish around, and particularly in the case where you went in 3 times, a couple of times it seemed like you did light up that left part of the septum, and yet, even though your intuition was getting into that high branch of the of the septal was the right thing to do from the beginning, you fished around and you found other septals that seemed to light the same area, and yet they weren't as effective. So I guess my question to you is, obviously every patient's different, and it seems like if there was some sort of more systematic way that one could map out septals that fed an area, so that, it's not quite, I don't know, is it that haphazard, or how did you finally get to the one, and how did your intuition guide you in that direction?
Yeah, we've done second ablation in about 30 patients, so it's not that common that we don't treat the right area, but it is. I think there's several problems. One is that the microcirculation, the septal branches, you can inject one. I think it frequently, the alcohol or the contrast goes further than you think it should. I mean, you notice the brightening of the septum was huge. Sometimes there would be multiple septals there, but the whole area would light up. So it's a little tricky, and I wish there was a better way to. Maybe you can help us think of a better way to.
Well, no, I mean it's fascinating, right? Because I mean, you said in that case you said I looked at it, I thought that high branch of that first septal would have been my first choice. You tried to wire it, and then you just had to kind of make compromises.
Right.
And I just wonder in this day and age of artificial intelligence, where you sort of aggregate the intuition you've gathered over the last 15, 20 years doing that, is there some way to crystallize that, map that, and give the operators who may not have as much experience as you, some sort of like, okay, number one, number two, number three, given that even injecting contrast itself seems not to always give you the answer. So it's some degree of intuition that you've gathered over the years.
John, I know you have a very low death rate. Do you have any insight into what these people are dying from?
You talking about?
The ones that you've done and then you intervened on, and then you just followed their course, and the death rate was like 1.2% to 2%. You're looking at it, I just wondered if are these any of them arrhythmic deaths, or are they ruptures, or what happens to them?
The patients that we are in the process of looking at our patients we treated. So the ones I showed you were published data, and I don't know what they died of.
Yeah, I mean, I'll chime in here. I mean, I now in about 10 years of doing this, it's been my experience that the arrhythmia post this procedure is lower than you'd think. I mean, I think that's more of a theoretical concern than actual concern. It sort of matches the data from Charleston and from Germany, that arrhythmic sudden death does not seem to be any more of a problem for this particular group, the alcohol septal ablation group, than the group at large has been our experience. So yeah, I mean, they're dying of other things. I mean, they're dying of stroke from AFib, they're dying from progressive heart failure, they're dying from cancer or whatever, but they don't seem to be dying from arrhythmias for whatever reason. I mean, the other, just a couple other, if I may, a couple other points I would make that, I mean, one, I just want to say that we've been very fortunate these past several years to have someone like Dr. Douglas here, because he really is extraordinary doing this, and he's right. I mean, just it can be a extraordinarily life-changing procedure for these folks who've been miserable for years, and then they have this done, and within a few days they're have a whole new lease on life. And I've also been struck that the amount of thinning you get from the septum is probably overrated. It's more the hypokinesis that we're causing, like you said. I mean, you get immediate relief of symptoms, and I've seen a lot of these patients who down the road there's not a lot of visual thinning of the septum, but they just have remarkably less gradient, and it's probably just from hypokinesis. It's probably the hyperkinetic septum was probably the real problem, more than the thickened septum. And then just by making that part of the septum relatively hypokinetic is really what does the trick. My last thing I'd want to say is I will put a little plug in for disopyramide that, I think I get referred a lot of patients who are on beta blocker therapy and are quite symptomatic. And I would say in our experience, a third to a half get a very good result from disopyramide if done right in properly selected patients and dosed right, et cetera, if they can tolerate some of the anticholinergic side effects. So there is a subset with disopyramide that you can get very good results as well. The problem is long-acting disopyramide, depending on your insurance, can be expensive, et cetera. So, and then my question for Dr. Douglas is there, you mentioned you're wary of thin septums, 15 millimeters or less. What about very thick septums? Have you guys looked at, or have we looked at those patients with extraordinarily thick, over 3 centimeter septums and how those patients do?
Yeah, we've done a few patients over 3, and I think they've done relatively well. Yeah, I haven't been impressed that they did not do well. Yeah.
I mean, that's sort of another theoretical concern that's out there. People say, oh, it's too thick, but I agree. I mean, I think that's sort of been our experience in a limited subset also. They tend to do okay with very thick. So don't be afraid if someone has a very thick septum, I guess would be our point.
Robbie, for either you or JD, with respect to sort of mitigating arrhythmic risk, right? So you look at the septal thickness on MRI. So 2 questions for you. One is, how is that affected by alcohol septal ablation, right? You're going to maybe change the septal thickness, and you said they may not have added risk, but do you make that risk assessment before the ASA? Secondly, if someone is at higher risk based on their septal thickness before the ASA, how do you get the timing of the ICD placement, and do you reassess them afterwards?
For the assessments, we would generally try to do the cardiac MRI prior to this procedure for someone who's going to have alcohol septal ablation for a couple reasons. One, right, to get sort of the true, and it's not even so much septal thickness, it's technically maximum, max LV wall thickness. So it's usually the basal septum, but it might be the apex or the anterior wall or inferior wall or wherever. But we're often ablating in that area, particularly a lot of these patients going for this procedure tend to have very thick basal septum. So you want to get that, not only the maximum wall thickness, but also the amount of delayed gadolinium enhancement is obviously going to be skewed by this procedure. The amount of scar is going to go up significantly. So you want to sort of get the amount of scar of the virgin ventricle, I suppose. In terms of risk of, I think the data would suggest that this doesn't seem to have a massive impact. There's sort of, again, this theory like, if they have alcohol septal ablation and they're borderline, well, now they're higher risk for sudden death. I'm not sure the data supports that. There's one study from the Mayo Clinic who have demonstrated their bias against alcohol septal ablation numerous times over the years, but every other study has not suggested that this increases your risk of sudden death dramatically. But if someone does need a defibrillator, we'll generally try to implant the device with an atrial lead because of the risk of heart block prior to the procedure. I know we've done that a handful of times where we've opted to put in a dual chamber device, ICD, before the procedure, so we have that backup pacing ready if needed.
So going back about 20 years ago, there was an interest in right ventricular pacing for these patients with outflow obstruction, sort of the opposite idea in part of what we do with patients with left bundle branch block and dilated cardiomyopathy with biventricular pacing, but to RV pace and get the septum to move in a different direction. Could you comment on, are there any patients these days that might be considered for that type of therapy? I know the data that was coming out of the NIH initially was not proven as helpful.
Robbie may want to comment. There have been, I think, two studies in which they looked at the patients, could turn the pacer off, and they did excess testing and collected their symptoms, and the results really weren't very good. Other than in some older patients, they seem to benefit. So, Robbie, do you want to make a comment about that?
Yeah, I mean, if someone has a device, particularly a dual chamber device anyway, we will often do a trial, and if Mike, oh, he's not here, Lloyd was here, but we'll often do a trial of RV pacing for these patients just to see if it helps. Off the top of my head, probably it maybe 1 out of 5 times the patients feel like it helps them at the cost of depleting their battery quicker, et cetera. But I would say the majority of patients do not get, I agree, much relief from RV pacing, but there are those that just do, just like in some patients, RV pacing seems to generate a lot of dysynchrony on echo visually, and others you can't even really notice it. So it's just one of those things you never know till you try. So I mean, I guess what I'd say is we would never implant a pacemaker for the purpose of RV pacing, but if they have one anyway, it's probably worth a try just to see. And every now and then you stumble upon someone who gets a pretty dramatic result. But in our experience, the majority of patients do not get much improvement.
Frequently, these patients have diastolic dysfunction, and it can be difficult to sort out whether the symptoms are due to diastolic dysfunction, due to outflow tract obstruction, or both. Do you have any tips on how you think about this issue and how you sort out who would be best treated medically?
Yeah. I think generally if the patient has symptoms and has outflow obstruction, we have gone ahead and done the ablation, and my impression is that they frequently are better. Robbie, you want to comment on that?
Yeah, I mean, I guess that's sort of the trick, and a lot of what we'll look at when we'll frequently review these echoes together before these procedures and look at these sort of parameters. I guess I would have sort of and sometimes you can get a sense, just based on the severity of the outflow tract obstruction by echo and the severity of the diastolic dysfunction. And, and oftentimes we'll counsel our patients before, particularly if they have advanced diastolic dysfunction and LVOT obstruction, that, sort of temper their expectations. But we've also found that in some of these patients, their diastolic function improves when you relieve the outflow tract obstruction, at least to some degree. I guess, have you ever, John, have you ever had a patient where you in the lab noticed an EDP of 35 or 40 before the procedure and said, well, I don't know whether maybe not called it off, but at least had to talk to the patient afterward, or at least had them change their medical therapy? There was some certain
we've certainly had a discussion with the patient. I don't know that we've ever counseled a procedure, though. We haven't done that.
I think that's fascinating, right? Because on the one end of the spectrum, you have people with the pure genetic form of the disease. They're young. They don't have other risk factors, as Creton says, for diastolic function. But to me, that's what's a little unclear, is if you look at the spectrum of patients you take care of, you've got the pure hypertrophic cardiomyopathy genetic disease, but surely on the other end, in the older population, you have this kind of mixed bag of, as you say, diastolic function, concentric LVH, now amyloid, right? It's coming up as a big, often misdiagnosis, and there it seems much more heterogeneous. And what I'm hearing from John is that, our experience is that it doesn't really matter which end of that spectrum you're in, that you might derive benefit. But, I guess that to me that second end is a much larger population, but I don't know if we have a lot of data that helps us figure out what to do with that crowd.
Yeah, I mean, I would say there's not much data, and if you relieve the outflow tract obstruction, some of these patients with diastolic heart failure, it does allow you to then sort of be a little bit more aggressive with their medical therapy, be it diuretics and after load reduction, that sort of stuff, which does help. So it's sort of get the dual benefit in that regard.
The preceding program is copyrighted by Emory University.